one thing that we found looking at the literature, which we thought was quite interesting, was when we compared Hispanic patients versus Black patients versus white patients in community practices and some academic practices in the Flatiron data, we found that Hispanic patients were more likely to be receiving chemotherapy, and Black patients were more likely to receive ibrutinib than white patients when compared to preferred regimens like acalabrutinib, zanubrutinib, and venetoclax plus obinutuzumab. So unclear why this racial disparity still exists, where underserved communities are getting not preferred regimens per the NCCN guidelines. And it, I think, comes down to assumption potentially, where maybe it's the assumption that somebody can't take off work to come into the visits, or has to be, or are viewed as, quote, non-compliant and need to be viewed as receiving the therapy. But these are all assumptions that I'm assuming, as opposed to actually having proved, because that's something that's very difficult to actually outline and prove. But overall, we now have seen overall survival benefits when small molecule inhibitors are instituted, even versus BR and FCR. And so ultimately, when we see survival benefits, we really have to be putting priority towards our novel therapeutics.